Welcome to the AFib Virtual Education Summit, sponsored by Johns Hopkins University School of Medicine on CardioCare Live. My name is Dr. Roy Ziegelstein, and you are tuned in to a live session called Changing Paradigm of Stroke Prevention with Novel Antithrombotic Therapies with Dr. Joseph Marine. Before we get started, I would like to remind our audience that we will be taking questions throughout the presentation. You can send us your questions to the box in the lower left-hand side of your screen. Dr. Marine is an Associate Professor of Medicine at Johns Hopkins University School of Medicine. Dr. Marine is also the Associate Division Chief of Cardiology for the National Capital Region, Section Chief for Cardiology of Johns Hopkins Community Physicians, and Associate Director of Electrophysiology for Johns Hopkins Health System. Dr. Marine completed his medical residency at the Brigham and Women's Hospital and his cardiology fellowship and EP fellowships at Boston University Medical Center and Beth Israel Deaconess Medical Center. I just wanted to point out that Dr. Marine will have a natural break in his presentation. We'll spend about 30 minutes with Dr. Marine presenting the topic, and then about 20 minutes total for questions and answers. But there'll be a natural break at about the first 10 minutes of the presentation. Dr. Marine will be discussing atrial fibrillation and stroke prevention generally, and so if you could send us your questions about that in the first 10 minutes, that would be helpful. Then he will be switching the topic to novel antithrombotic therapies for the latter part of his talk. Joe?
Thank you, Roy, and I'd like to thank the organizers for having me on the program to talk about this very important and timely topic. Here is our disclosure slide. We have no competing interest to disclose. During the presentation, the following investigational drugs and devices will be mentioned: Pixaban, which is not yet approved by the FDA, Zymeligatran, which is not as well, and atrial appendage occlusion devices, which are also investigational. So I'd like to start the program just by getting a sense of who our audience is, since we can't see you. So making use of your interactive feature of this program, I'd like to start by asking everybody from where are you viewing this program? A, USA, B, Canada, C, South America, D, Europe, and E, Asia, Australia, or Africa.
So Joe, vast majority of people in the audience, about 90%, are from the United States, and the rest mostly from Europe.
Oh, great. So we have an international audience. And our second question is, approximately how many patients with atrial fibrillation do you see in a typical month? None, 1 to 5, 6 to 10, 11 to 20, or more than 20?
So Joe, this is quite a spread. The most common answer here is that most of the audience, about a third, sees between 1 and 5 patients. Another third or so between 6 and 10, and then about 10 to 15% spread out over the remainder, with about 10% of people saying that they see none. Next slide.
So a pretty broad spread. So I think this underscores that atrial fibrillation is probably the most common sustained arrhythmia that we all see. This slide shows a typical ECG of a patient with atrial fibrillation. As we all know, it's an important cause of stroke with approximately 20% attributable risk in the elderly. Many patients have significant morbidity from symptoms including palpitations, malaise, loss of exercise tolerance, and reduced quality of life. In a minority of patients with poorly controlled rate, they may develop congestive heart failure and systolic dysfunction. And we know from epidemiologic studies that atrial fibrillation is associated with increased mortality ranging from between 1.2 to 2-fold excess. We're also very much aware that atrial fibrillation is a very common arrhythmia and that it increases markedly with age. This is data from the ATRIA study, which is a cross-sectional analysis of 1.9 million Kaiser Permanente members in California, taken between a year or two between 1996 and 1997. About 18,000 of these patients, or 1%, had atrial fibrillation, and you can see almost an exponential increase with age with very, very few people, less than 50, having atrial fibrillation. But by the time one reaches the age of 80 and older, the prevalence is approximately 10%. This works out in the USA to prevalence somewhere between 2.5 and 5 million is the current estimate, and this is expected to double by 2040 due to the aging of the population. So the goals of atrial fibrillation management, one of the most prominent in all of the guidelines, is to reduce the risk of thromboembolism in addition to preserving ventricular function, minimizing symptoms, and maximizing quality of life. Throughout the talk, I'll make reference to the 2006 ACC-AHA atrial fibrillation guidelines. These were published in 2006. They're in the process of being updated. There was a focused update in 2011 dealing specifically with dronedarone and dabigatran. The European Society of Cardiology issued their own guideline statement in 2010 and updated that in 2012. So atrial fibrillation, as we know, predisposes to the risk of thromboembolism. And in the TEE panel that I have in the upper right, it shows at the highest point the left atrium, and coming off that is the left atrial appendage with a large thrombus in it. And this is the site of most sources of emboli in atrial fibrillation. Approximately 90% come from the left atrial appendage. And this is due to the factors of stasis, endothelial dysfunction, and hypercoagulability. Of course, when this clot embolizes to the brain, it causes a stroke, but emboli can also occur to the intestine, to the leg, or even to the coronary artery. The overall risk in untreated patients with atrial fibrillation is in the range of 2 to 5% per year. So we'll go to another question. An 82-year-old woman is referred for an opinion about treatment of atrial fibrillation. She has a history of hypertension, diabetes, and permanent AF, treated with a pacemaker and AV node ablation. Which of the following medications is most appropriate for her? A. Aspirin, B. Clopidogrel, C. Dronedarone, D. Warfarin, E. Amiodarone.
So Joe, about 90% of the audience, 85, says warfarin. Mm-hmm. The remainder are split between aspirin and clopidogrel.
So I would agree with the majority. Warfarin is the right answer. Dronedarone and amiodarone, I would say, is not correct because we've posited that this patient is now in permanent atrial fibrillation, and so rhythm control would not be appropriate. And we'll talk about why aspirin and clopidogrel wouldn't be appropriate for this patient with a CHADS-2 score of 3. So that brings up the subject of scoring systems for estimating stroke risk in patients with atrial fibrillation. The most widely used, at least in the United States, is the CHADS-2 score. And this is an acronym which stands for CHF, the H stands for hypertension, the A stands for age greater than 75 years, D stands for diabetes, and S stands for stroke, which is a double risk factor, and so it gets 2 points. And in the top panel there, it shows how many points you get for each one of these different risk factors. And so the maximum score that one can have is 6. The panel below shows how the CHADS score in epidemiologic studies very nicely predicts the adjusted stroke risk. When somebody with a CHADS-2 score of 0, the adjusted stroke risk is approximately 1.9% per year, and then it linearly increases up to a risk of 18% per year in those with a CHADS-2 score of 6. Current, the 2006 ACC guidelines suggest using the CHADS score to stratify for what type of antithrombotic therapy one should use. In patients with a CHADS-2 score of 0, aspirin alone is recommended. For patients with a CHADS-2 score of 2 or more, oral anticoagulation, either warfarin, dabigatran, or now rivaroxaban, is recommended. And for those with a CHADS-2 score of 1, aspirin or oral anticoagulation may be considered. Other factors which may influence the decision, particularly in those with CHADS-2 scores of 1, are other risk factors such as left ventricular hypertrophy, left atrial enlargement, the presence of coronary artery disease, or more intermediate older age of 65 to 75. And as we'll talk about in upcoming slides, some of these are also components of the CHADS-VAS score. However, one would usually anticoagulate in the presence of hypertrophic cardiomyopathy, amyloidosis, thyrotoxicosis, and rheumatic mitral stenosis, regardless of the CHADS-2 score, because of the elevated risk conferred simply by the presence of these diseases. And a final point to make is that one would generally not withhold anticoagulation for minor bleeding or simply for perceived fall risk. Now, of course, we have the CHADS-2 VAS score, which has been adopted in Europe and Canada, and this slide illustrates the differences and similarities between the two scoring systems. So on the left, we have the CHADS-2 score with a total score of 6. On the right, the CHADS-2 VAS score with a total score of 9. Some of the points, such as congestive heart failure, hypertension, diabetes, and the double risk factor of stroke TIA, is the same between the two, but age greater than 75 confers 2 points in the CHADS-VAS score, and you also can get a point for having vascular disease, either coronary or peripheral vascular disease. Age of 65 to 74 confers a point, and female gender also confers a point. And so this somewhat more complicated scoring system has been adopted and endorsed by the European Society of Cardiology, and from what I understand is being discussed to be incorporated into the new US guidelines as well. This slide shows how anticoagulation is guided by use of the CHADS-VAS score in the European Society of Cardiology guidelines. Once one assesses the CHADS-VAS score, if one has a score of 0, in general no therapy is recommended rather than aspirin. However, if one has a CHADS-2 VAS score of 1 or greater, oral anticoagulation is suggested. If the CHADS-2 VAS score is 2 or greater, it is a Class 1 recommendation, and if it's 1, it's a Class 2A recommendation. Another point, in addition to having a lower threshold for anticoagulation than the US guidelines, is the ESC guidelines explicitly suggest using or considering the newer oral anticoagulants over warfarin. A couple other points to make in general about anticoagulation in special situations. In patients who are undergoing cardioversion, patients should be anticoagulated approximately a month before and a month after cardioversion, regardless of what their CHADS-2 or their CHADS-VAS score is. Transesophageal echocardiogram can substitute for the anticoagulation a month before, but cannot substitute for anticoagulating afterwards. In patients who are undergoing rhythm control with antiarrhythmic drugs, one of the very important points that we learned from the AFFIRM trial is that one should generally continue anticoagulation therapy based on their risk of thromboembolism and not based on whether they're in atrial fibrillation or sinus rhythm when you're seeing them in the office. And then finally, for patients undergoing AF ablation, current HRS guidelines suggest a minimum of 2 months of anticoagulation after the procedure, and then further anticoagulation based on risk factors and rhythm status. So with that, I think we'll pause and see if there are any general questions on anticoagulation therapy before we launch into a discussion of specific agents, particularly the newer agents.
Thank you, Joe. First, I wanted to mention for people who are joining us during the presentation, this is CardioCare Live, presentation on atrial fibrillation, stroke prevention, and novel antithrombotic therapies for the prevention of stroke. With Dr. Joseph Marine, Associate Professor of Cardiology at Johns Hopkins University School of Medicine. So there are a few questions, Joe, that are interesting. One has to do with age, and the question is, what's going on with age electrophysiologically that makes people at greater risk of atrial fibrillation as they get older?
That is a great question, and as we age, our left atria become slightly larger, even independent of risk factors such as hypertension or diabetes or coronary disease or other forms of cardiomyopathy. And we certainly know that enlargement of the atria alone can create greater predisposition for atrial fibrillation. And then I think secondly, that is that as we age, we also develop other diseases that create risk for AF, such as hypertension, diabetes, and other forms of cardiomyopathy. We also know that as we age, there's more fibrosis of the atrium, and that is certainly a factor as well. So it's probably atrial enlargement and microscopic fibrosis. There may, in addition, be factors such as changes in autonomic function and autonomic innervation of the atria. We understand a little bit less about that, but those may be cofactors as well.
Thanks, Joe. Another question has to do with anticoagulation in the peri-conversion period. And I'm just going to rephrase the question here a little bit and say you made a point of saying that anticoagulation should be continued certainly before a cardioversion and then after cardioversion. Could you explain why that is, even if sinus rhythm is restored?
Sure. So I think the question kind of gets to when do thrombi form in the left atrium in the setting of atrial fibrillation. And they can form before the time of cardioversion, that is, they can form due to stasis and the other factors that I mentioned prior to the cardioversion, and therefore embolize shortly afterwards. But in addition, in someone who's in atrial fibrillation, particularly for atrial fibrillation of long duration, after one cardioverts, there can be stunning of the atrium and failure of the left atrium and the left atrial appendage to contract normally. So that condition of stasis may then continue even after cardioversion. And that's probably the more true the longer you've been in atrial fibrillation. So that's the reason for anticoagulation both before and afterward.
Thanks, Joe. There's another question here that's interesting, which is about the role of aspirin, not as a sole agent, but in combination with warfarin. Under what, or with anticoagulants, under what circumstances would you recommend that someone who's being anticoagulated with warfarin or one of the newer agents also take aspirin?
Yeah. Well, addressing warfarin in particular first, we certainly know that combination of any of the anticoagulants, whether warfarin or the newer agents, with an antiplatelet agent does increase the risk of bleeding. So I think that has to be considered very carefully. And in general, I wouldn't combine the agents unless one has a very specific reason for doing so. One example I can certainly think of is somebody with a coronary stent, where the risk of stent thrombosis requires continued antiplatelet therapy. I think that's the kind of patient where one would almost always want to continue both agents. For patients who have other risk factors such as just coronary disease without stenting or carotid artery disease, for example, I think you would have to individualize that a little bit more, but if one does use aspirin, I generally would use the lowest dose of 81 milligrams daily. In general, if it's for purely prophylactic purposes, I would generally stick with just the oral anticoagulant and not use an antiplatelet agent because of the increased risk of bleeding.
And I think another situation that some people talk about is if there's a mechanical heart valve and atrial fibrillation. Some people use both as well. Another question here relates to when would you recommend stopping anticoagulation if someone's about to have a procedure, like an operation?
So which we just brought up warfarin. So for warfarin, it would depend a little bit on the procedure. And interestingly, in the field of electrophysiology, we've been had to deal with this bridging question for a number of our procedures, such as device implantations, for quite some time. And I think we've evolved in the EP community to trying to generally continue warfarin throughout the duration of the procedure. So for somebody, say, with a mechanical mitral valve in the presence of atrial fibrillation, someone who's at a very high risk of thromboembolus with even a short interruption of anticoagulation, we're generally just continuing warfarin without interruption through the perioperative period, and finding through both retrospective studies and through one randomized study that that's safer actually than intravenous anticoagulant bridging. So I think this is something you have to negotiate with your surgeon and would depend upon the nature of the surgery, the nature of the bleeding risk with the surgery, and the risk for having thromboembolism off anticoagulation. Those are the kind of risk benefits. In general, somebody with a higher risk of thromboembolism. You'd want to minimize the duration off the oral anticoagulant and consider intravenous or subcutaneous heparin bridging.
Great, thanks. Well, I'm going to just pose one more question before we move on to the next part of the talk. I'm going to combine several questions here into one, which deals with the issue about anticoagulation around an ablation. Why do we need to do it after, and how long? And when would you feel comfortable saying to a patient who seems to be in normal sinus rhythm after an ablation that he or she can stop?
So there's two categories of ablation, just to be clear. So when one is doing an AV node ablation, as in the case that I presented in question 3, that's a patient who's going to continue to be in atrial fibrillation, and so their ablation would not affect the decision. You'd need to continue anticoagulation therapy in this patient. For patients who are undergoing primary ablation for rhythm control of atrial fibrillation, pulmonary vein isolation, or some variant thereof, it's a very interesting, controversial, and I think changing topic. The current HRS guidelines recommend continuing anticoagulation indefinitely in patients with a CHADS-2 score of 2 or greater. There are emerging data from some centers that in patients who achieve good rhythm control at 6 months or 12 months, their risk of thromboembolism off anticoagulation becomes very low, even with those higher CHADS scores. I think that until we have further data and further endorsement from professional societies, I generally stick to the HRS guidelines and use their thromboembolic risk rather than their rhythm control, because we know that after ablation, patients can continue to have asymptomatic episodes of atrial fibrillation that they may not be aware of, and so may continue to predispose them to risk.
So it sounds like a corollary of that is that if a person's CHADS-2 risk is 2 or greater, that ablation should essentially never be done for the purposes of allowing them to come off of anticoagulation. Is that a fair?
Yes, I think that is, and that is, I think, explicitly stated in the HRS guidelines that in general, a desire to come off anticoagulant therapy should not be used as the sole rationale for ablation therapy, because we just don't have hard evidence yet that it reduces stroke risk. There is an ongoing international trial called Cabana, which I would encourage any of our viewers to, if they have an enrolling center near them, to enroll patients. That's one of the questions that the Cabana trial is going to try to answer. This is a 3,000 patient randomized trial of ablation therapy versus medical therapy.
Great. Thanks, Joe. For those people joining us again in the middle, this is CardioCare Live discussion with Dr. Joseph Marine, Associate Professor of Cardiology at Johns Hopkins University School of Medicine, who's talking to us about atrial fibrillation, stroke prevention, and newer antithrombotic therapies. Joe?
Great. So we'll get our slides back up in just one moment, and we'll begin to talk about more specifically the newer anticoagulants that have added really a lot of excitement to the field. This has been a field of anticoagulation for atrial fibrillation has not had so much new information in quite some time. So we're just technically working on getting our slides back up. Hopefully it will just be another minute or so. Are you seeing anything, Roy?
Yes. Would you like me to read the question in the meantime? I can.
All right, great.
There we go.
So we'll start this segment off also with a question. A 56-year-old man presents with persistent atrial fibrillation. He has a past history of chronic kidney disease with an estimated creatinine clearance of 15 mLs per minute, as well as rheumatic heart disease, status post-aortic valve replacement with a bioprosthesis. He does not like the idea of having frequent blood draws. Which anticoagulation strategy would be most appropriate for him? A, rivaroxaban, B, aspirin plus clopidogrel, C, warfarin adjusted to INR between 2 and 3, and D, dabigatran.
So Joe, again, we have a nice spread of answers that'll fuel a discussion. About 60% of the audience chose dabigatran. About 20% chose warfarin. About 12% chose rivaroxaban, and 7% chose dual antiplatelet therapy with aspirin and clopidogrel.
Mm-hmm.
Next slide.
Great. So this gives us much to talk about. Well, we're, I think, all familiar with the effectiveness of warfarin from a number of trials conducted in the 1980s and 1990s, which I summarize in this slide here. 5 different trials, which in summary show an approximate 66 or 65% relative risk reduction of thromboembolism with warfarin. So it's now well established that warfarin in patients with risk for thromboembolism and atrial fibrillation does reduce that stroke risk significantly. However, I think we're all familiar that there is quite a number of limitations to warfarin. There is difficulty maintaining a target INR. A number of studies have shown that even in the most optimal circumstances, the time in therapeutic range, or TTR, is only about 60 to 70%, even in the ideal circumstances of a randomized trial. There's also the cost and inconvenience of testing and dose adjustments. On the panel below, it shows a patient of mine who's followed in an excellent anticoagulation clinic. You can see that the target INR for this patient with a mechanical valve is between 2.5 and 3.5, and the INRs scattered over several years you can show as sort of a scatter plot with probably only a third being between the lines, and this just reflects the difficulty of maintaining appropriate therapeutic INR in some patients. And when the INR goes significantly above 4, there's a risk of hemorrhage, and when the INR goes below 2, there's a risk of breakthrough thromboembolism. This is more data on that point published in 2006, illustrating the narrow therapeutic index of warfarin, showing that on the x-axis as one's international normalized ratio, or INR, goes higher and higher, the risk of intracranial bleeding, particularly once one gets above 4, starts to go up significantly. On the other hand, when the INR goes below 2, the risk of ischemic stroke goes up substantially. And this probably accounts for why warfarin isn't optimally used in a general population. Most studies shows that only around 50 or 60% of patients with atrial fibrillation who are appropriate candidates for anticoagulation actually receive warfarin therapy. And so the unmet need for newer anticoagulants is certainly present. Now, what about the role of aspirin? I think to summarize the literature on this, limited efficacy, but probably a little bit better than placebo. This is an analysis published in 2006 or 2005, comparing the relative risk reduction with warfarin on the left in the red bar, about 66% or 68%, aspirin versus no antithrombotic therapy, about a 20% risk reduction, and the adjusted dose anticoagulation versus aspirin, 50%. So warfarin is clearly superior to aspirin, but aspirin slightly better than no therapy. What about the newer antiplatelet agents? With the release of clopidogrel, there was some interest in investigating whether the combination of aspirin and clopidogrel may be equivalent to warfarin, and so a couple of trials were set up to test that hypothesis. On the top panel, we have the summary of the ACTIVE-W trial, which is a trial of 6,700 patients with atrial fibrillation and risk factors who were randomized to either receive dose-adjusted warfarin or the combination of clopidogrel and aspirin. And you can see that the total stroke rate was approximately double in the patients who were randomized to clopidogrel and aspirin. So it clearly answered the question that combined antiplatelet therapy is not equivalent to warfarin. The ACTIVE-A trial looked at a group of patients who were deemed to be inappropriate for warfarin anticoagulation, either by their physician or the patient refused to take warfarin. So this was a group of 7,500 patients who were randomized to either receive aspirin plus clopidogrel or aspirin alone. And you can see that the difference between the two curves is much less. It did reach statistical significance. However, the increased major and minor bleeding offset that slight benefit of reduction in ischemic stroke. The combination of aspirin and clopidogrel does not have an FDA label for that indication, and it currently is a Class 2B recommendation of the 2011 ACC-AHA update. So that brings us to the new oral anticoagulants, and this slide shows a summary of the coagulation cascade, which I thought as an interventional electrophysiologist I was never going to have to deal with again, but here it is, and this shows where these newer anticoagulants affect the coagulation cascade. Looking farthest down the cascade at the thrombin level, we have the direct-acting thrombin inhibitors, of which dabigatran is the current available agent. And on the right side, we have several factor Xa inhibitors acting one step upstream, acting as directly inhibiting factor Xa. Rivaroxaban is the currently approved agent, and we also have apixaban and betrixaban and edoxaban as investigational agents. Zymalegatran was the first oral direct-acting thrombin inhibitor to be tested in a major phase 3 trial, and I apologize that we don't seem to have the, there we go. So this is the summary of the Sportif 3 and 5 trials combined, comparing the warfarin, dose-adjusted warfarin, versus zymalegatran for stroke prevention in patients with atrial fibrillation. And you can see from the analysis that they are equivalent in reducing the endpoint. However, 6% of patients in these trials had elevated liver function tests, and there were 2 cases of fatal liver failure among those, so this drug was turned down by the FDA. And of course, we now have dabigatran, dabigatran, which has been approved as the first approved new direct-acting thrombin inhibitor on the basis of the RELY trial, which is shown summarized in this slide. The RELY trial looked at 18,000 patients, a very large study. They had a mean age of 71 years. Patients had to have a CHADS-2 score of 1 or greater, and the mean score in this trial was 2.1. 20% of these patients had a prior stroke. Patients were randomized in an open-label fashion to either receive dabigatran 150 milligrams twice daily or 110 milligrams twice daily, and the third arm was dose-adjusted warfarin. And the summary statistic here shows that warfarin and the lower dose of dabigatran was equivalent in terms of efficacy with less major bleeding. The higher dose of dabigatran, 150 milligrams twice daily, had improved efficacy at lowering the endpoint of stroke and embolism with equivalent major bleeding. And if we move to the next slide, this shows that the results of the RELY trial appeared to apply across different risk groups. So whether your CHADS score was 0 or 1, 2 or 3 or greater, the higher dose of dabigatran appeared to improve outcome. And this panel here shows event rates compared between warfarin and dabigatran 150 milligrams twice daily, the higher dose that was ultimately approved by the FDA. So the endpoint of stroke or embolism was significantly improved with the higher dose of dabigatran. Intracranial hemorrhage, interestingly, was much lower with the new agent, 0.1% per year versus 0.4% per year. The death rate was slightly better in the dabigatran group over warfarin, but did not reach statistical significance. One point that has been raised was the myocardial infarction rate was slightly higher in the dabigatran group. The explanation for that still remains somewhat unclear. GI bleeding was clearly higher in the dabigatran group, about 50% higher. However, the total major bleeding rate was equivalent. The major bleeding rate was equivalent. The total bleeding rate was lower, and the composite, sort of summing up the good and the bad, was lower, was improved in the dabigatran group over warfarin. This slide summarizes other adverse events. There was a slightly higher discontinuation rate in the dabigatran group, and that was primarily due to the side effect of dyspepsia. So there were twice as many patients who had significant dyspepsia with either dose of dabigatran than with warfarin, approximately 12% in the new therapy group versus 6% in warfarin. They looked very carefully at liver function tests in this trial, and they found no signal of liver toxicity with the drug. So key points to summarize with dabigatran: this is a direct-acting thrombin inhibitor. It has a half-life of about 12 to 17 hours. It's renally excreted. One uses a fixed dose with no monitoring recommended, 150 milligrams twice daily for those with creatinine clearance greater than 30, 75 milligrams twice daily if the creatinine clearance is 15 to 30, and use is not advised if the creatinine clearance is less than 15 or there's end-stage renal disease. It's, I think, important to point out that the 75 milligram dose is recommended on the basis of pharmacokinetic modeling rather than direct evidence. The patients with this creatinine clearance were not studied in the RELY trial. Another important point to emphasize is that the only approved indication for dabigatran is non-valvular atrial fibrillation. It is not approved for DVT, pulmonary embolism, or for thromboprophylaxis of heart valves. Another point is that a sub-analysis of the RELY trial suggested that the drug can be used as equivalent to warfarin for cardioversion. Major adverse drug effect, as I mentioned, is dyspepsia and GI bleeding, and one major drug interaction is rifampin, which is a P-glycoprotein inducer, may lower doses of dabigatran. Concern has been raised about bleeding risk of the new agent in post-marketing analyses, and some government agencies have taken up the task of looking into this further. Some of you may have seen some of these coming across HeartWire and other news sources. I don't think we know too much about this yet, other than some risk factors for elevated bleeding with dabigatran include age greater than 75, having renal dysfunction, and co-administration of antiplatelet agents. The concern about bleeding risk with the newer agents has led to some further analysis of use of coagulation assays. Although evaluation of assays is not generally recommended for use, in general the drug will elevate the PTT, the activated partial thromboplastin time, although the correlation is not as good as for the eccrine clotting time or for the thrombin time. This slide summarizes the ESC guidelines in terms of management of bleeding in patients who do have bleeding on either warfarin or the newer agents. For warfarin, treatment with vitamin K, fresh frozen plasma, and monitoring of the INR is mentioned. However, there really is no clinical data for how to manage bleeding in patients with the newer agents. Dabigatran is dialysable. Factor 7A concentrates or prothrombin complex concentrates may be considered on the basis of some animal studies and studies in normal volunteers. So we'll move on to the other approved new agent, rivaroxaban. This agent was approved on the basis of the ROCKET-AF trial, which is summarized here in this slide. 14,000 patients with AF and a CHADS-2 score of 2 or greater, which is a higher level of risk than patients in the RELY trial. And these patients had a mean CHADS-2 score of 3.5. 55% had a prior stroke, so a significantly elevated, significantly sicker population, I would say, than the RELY trial. These patients were randomized to one of two arms in a double-blind, double-dummy fashion, either to rivaroxaban or to dose-adjusted warfarin. Patients were treated with rivaroxaban 20 milligrams daily if their creatinine clearance was 50 or greater, and if it was between 30 and 49, they were treated with 15 milligrams daily. This trial showed equivalent efficacy in major bleeding rates with slightly lower intracranial hemorrhage rate for rivaroxaban. As with dabigatran, the GI bleeding was 50% higher in the rivaroxaban group than the warfarin group. And this drug, on the basis of this trial, was approved by the FDA for non-valvular atrial fibrillation in November of 2011. There was some controversy with this approval. One of those points was that there's a once-daily dosing of this drug, despite the fact that it has a a relatively shorter half-life of 5 to 9 hours. Another point that was raised in the consideration of this drug was that there was a relatively low median time in the therapeutic range in the warfarin-treated group of around 58%. And then finally, there were higher event rates seen during transitions of anticoagulation, and so there is a black box warning for rivaroxaban highlighting this fact. The expense of the medication is generally similar to dabigatran, and the relative value of this agent versus other oral anticoagulants is certainly remains to be determined, but its once-daily dosing is an attractive feature, I think, for some patients. In terms of clinical use, the dosage is 20 milligrams with the evening meal in patients with creatinine clearance of greater than 50. For creatinine clearance of 15 to 50, 15 milligrams with the evening meal. However, I think again it's important to note that the dose in patients with more significant renal dysfunction, 15 to 30 mLs per minute creatinine clearance, was not studied in ROCKET-AF, and this again is recommended on the basis of pharmacokinetic modeling. In patients with more severe renal insufficiency, creatinine clearance of 15 or less do not use. For patients with moderate to severe hepatic impairment, it's also recommended that the drug not be used. One should avoid concomitant use of strong P-glycoprotein and CYP3A4 inhibitors or inducers such as dronedarone and ketoconazole in particular. I think some of the HIV protease inhibitors also fall into that category. There is no established reversal agent, and this agent is not dialyzable. The package insert contains some advice for bridging therapy in patients who have to come off the drug. The next slide tries to compare some of the basic features of the three available oral anticoagulants in the United States: warfarin, dabigatran, and rivaroxaban. One of the advantages of warfarin is that we have decades of experience with the drug. We probably know just about everything we're going to know. With the newer agents, obviously, with less experience, there's likely we're going to learn more about it with clinical usage in the many, many patients who will take the medication. The evidence basis for warfarin is based on a number of smaller trials where we have one very large trial for dabigatran and rivaroxaban. The cost is significantly higher for the newer agents, but that's somewhat offset by the lack of need for any monitoring. The indication for warfarin is very broad: all types of atrial fibrillation, DVT, PE, heart valves, any kind of thrombosis risk can be treated with this agent. However, dabigatran is only indicated for non-valvular atrial fibrillation, and rivaroxaban is only approved for non-valvular AF and DVT prophylaxis at a lower dose. The excretion of warfarin is hepatic, the excretion of dabigatran is renal, and rivaroxaban is a combination of renal and hepatic excretion. As we talked about, there are established reversal agents for warfarin, not yet for the newer agents. The dosing is once daily for warfarin, twice daily for dabigatran, and once daily for rivaroxaban. We talked a little bit about monitoring as well as the drug interactions. We also have a newer agent on the horizon, apixaban, and this is an agent which is not yet approved in the United States. However, there are a couple of very interesting trials suggesting that this may also be another very useful agent in the future. The Averroes trial looked at 5,599 AF patients with at least one stroke risk factor who were deemed by their physician not to be candidates for anticoagulation. So these were warfarin ineligible patients. And they were randomized to either receive apixaban 5 milligrams twice daily or aspirin. And the interesting thing about this trial is that despite the expected finding that apixaban was much superior in reducing stroke risk in the panel on the left, the bleeding risk was actually equivalent to aspirin. And in the larger pivotal Aristotle trial, 18,000 patients with warfarin, AF who were eligible for warfarin were randomized to warfarin versus apixaban in a trial that was otherwise fairly similar to ROCKET-AF. And in this trial, there was a lower stroke and embolism with apixaban, lower major bleeding, lower intracranial hemorrhage. Interestingly, in this trial, there was no difference in GI bleeding versus rivaroxaban and dabigatran. However, there was also a statistically significant reduction in mortality with apixaban. So both of the previous trials with the other newer agents showed a trend in that direction, but with apixaban it crossed the line into a statistically lower mortality. I think I will skip through the section on stroke prevention with mechanical devices. These are agents that are being investigated, and I think I would just summarize them by saying that it's an attractive concept. The PROTECT AF study with one of the left atrial appendage occlusion devices did show equivalent reduction in stroke with the cost of an increased risk of complications early after the procedure, and so these devices are still undergoing further investigation. So in summary, we've talked about the use of risk scores in evaluation patients for anticoagulation for AF. Anticoagulation is recommended for most. Warfarin is the traditional agent. We now have well-established experience with dabigatran as a well-established alternative. One has to use caution in patients with chronic kidney disease, advanced age, and in patients who are on antiplatelet agents. Rivaroxaban has recently been approved. The apixaban data looks very promising, although as I said, it is not yet FDA approved in the United States. And the FDA, the left atrial appendage occluder devices are an attractive concept as an alternative to anticoagulation, but still need to improve their safety. So I'll turn it back to Roy, who will see if we have any questions.
Thanks, Joe. I think that from monitoring the questions as they're coming in during your presentation, I think that the audience is a very happy one, because as they were asking questions, you seem to anticipate it by including it in your presentation. I have three questions to start off. First, can you answer the question you posed? Which was, I think, question number 4. I don't think we ever reviewed the answer. So remember that about 60% or so of the group thought dabigatran.
Very good. So this was a patient who had rheumatic heart disease, had an aortic valve replacement with a bioprosthesis, and had severe renal insufficiency. So the correct answer for that patient was warfarin. The newer anticoagulants would not be appropriate for this patient, both on the basis of having severe renal insufficiency and on the basis of having significant rheumatic heart valve disease.
Thanks, Joe. I think that's an important point. A couple of questions. These newer agents seem to be so tied in with kidney function. I know that for my patients, and my guess is for many of the patients of many of the audience here, the serum creatinine and the creatinine clearance tends to fluctuate a lot.
Yes.
Maybe not quite as much as the INR in your slide earlier, but it fluctuates a lot, depending on what their medicines are, what their volume status is, what their other comorbidities and intercurrent illnesses are. How often would you check serum creatinine and assess creatinine clearance in a patient on one of the newer agents?
Yep, that's a very, very important point. So with warfarin, we don't really have to be concerned with renal function, but with both of the newer agents, we do, particularly for dabigatran, which is more renally excreted than rivaroxaban. The product information recommends checking a baseline creatinine clearance and then periodically assessing it. It does not give a defined interval, but I think that anywhere in a 3 to 12 month range would be reasonable, depending upon where you're starting with and whether the patient is on agents such as diuretics, which may cause change in their creatinine clearance. I have to say that in general, it's one of the factors that I consider in choosing whether to use a newer agent or whether to use warfarin. And somebody who has borderline renal function, I think the management becomes much more complicated in that patient, and you do have to be more concerned, particularly the older they are, the more they're on medications or have comorbidities that may affect fluctuations in renal function, and then finally if they're on agents that affect P-glycoprotein excretion or CYP3A4, those become more of an issue in patients with borderline renal function.
Thanks, Joe. One of the sort of attractive things about warfarin is that we usually can tell when a patient of ours is not taking it because we have a readout, if you will, with the INR. What do we do with the newer agents? How do we figure out if someone is actually taking it other than simply asking them?
That's a great question, and it raises a number of points. I think that we all find that some of our patients actually like coming to anticoagulation clinic, and some patients choose to stay on warfarin for that reason, and I generally fully support that. If patients are doing well on warfarin and they like, they get some benefit out of the social interaction and the medical interaction of seeing a Coumadin nurse, I think that's perfectly fine and should be supported. In terms of the question of what to do.
How do we figure out if someone's taking the medicine since we don't have the
that is a
readout?
very difficult question, and some patients actually like the concept that you can check and you know that they're in that correct range, they're not too high, they're not too low. With the newer agents for dabigatran, the activated PTT, the standard test that we generally order in patients on intravenous heparin, that should be elevated in general in somebody who is taking the agent. So if the PTT is normal, it's a reasonably good chance that the patient is not taking one or more doses. For the agent rivaroxaban, the PT, the prothrombin time, should be elevated, although the correlation there is not quite as well established. I think we have to rely on patient compliance and asking them directly. So for our patients, for example, who come in for cardioversion and they're taking dabigatran, we're certainly very careful to ask them very specifically, are you sure you've taken every dose, including this morning? Because the consequences of not doing that is potentially a stroke. So I think it's a combination of talking to your patients and questioning them directly, and then in cases where you're unsure, you can consider using one of those two tests.
Thanks, Joe. One of the members of the audience asked what your feeling is about the older patient, in particular, those over the age of 75, and the newer agents.
I think that I wouldn't exclude use of the newer agents on the basis of age alone. I think as clinicians we're all familiar that the group of people who are over 75 encompasses a very, very broad spectrum. I think other factors such as other medications that are used, comorbidities, borderline renal function would all play into that role, but I wouldn't exclude use of the newer agents solely on the basis of age.
Thanks. This is a question from the audience. What drug would you recommend in a patient who's 70, very active, and has had 2 previous minor strokes?
That's a good question. I think that in general I would probably think about the newer agents because they've been clearly shown to have a lower risk of stroke and a lower risk of intracranial hemorrhage. So in that kind of patient, particularly a very active patient, that may be someone who is less inclined to want to undergo monitoring. The European Society guidelines have certainly come down on recommending the newer oral anticoagulants for that type of patient over warfarin. They're still considered to be equivalent in the U.S. guidelines, but that's somebody that I would probably think of one of the newer agents over warfarin.
Joe, a quick last question. You very nicely outlined the CHADS-2 and the CHADS-2 VASC for risk prediction in terms of stroke. Is there any way to predict what a person's risk of having a stroke is when we stop anticoagulation, for example, for an operation? Is the CHADS-2 or CHADS-2 VASC helpful there, or do we really have no way of guiding what to do? I
don't think there's as much clinical data about that. I think it would stand to reason that patients with higher risk scores are going to be at greater risk in an unanticoagulated interval. So I generally think that it's useful in making determinations about bridging to consider CHADS score and CHADS VASC score. And another thing I would just point out is that the ROCKET-AF trial did show a higher risk of thromboembolism after coming off rivaroxaban in that trial. So that's particularly a situation where you have to be careful and consider bridging. Thank you, Joe. And thank you very much for your time and that great presentation. I'd like to thank BI for their support of this important educational series. Please remember to complete the quiz at the end of this session to secure your CME credits. And stay tuned for Dr. Bob Giuliano on a presentation on what do updated guidelines mean for your patients with AF.
My name is Dr. Roy Ziegelstein, and I thank you for joining us.